joint space narrowing, avoidance, and man-aligned. How to treat rheumatoid? Again, we'll go back to the osteoarthritis things. You need pain control, improve function, and in this particular patient, you need to prevent progression of disease. So your treatment will be into like categories. Number one, if the patient is complaining of pain, I need to control the pain. Number two, I need to do some really workout for this patient. Need to refer on to physiotherapy, and I need to discuss with the patient the options. What are the options that I need to give you to prevent? Otherwise, the patient after a year or two will be staying home with wheelchair. Therapeutic classes, I think you remember non-steroidal, and keep in mind it can cause GI ulcer, GI upset. Sometimes you give proton pump inhibitor with them. Steroids, you can give it for a temporary period, you can't give it for a long time because of side effects. So we give, for example, prednisone like 40, 50 milligrams, then we taper it to 5 milligrams slowly every week, like 5 milligrams. Then once the patient reaches 5 milligrams per day, you keep the patient with this for some time. And ask the patient to start to stop it, or to keep it alternating day yes, day no. And see what happens. If they can stop it, that's really good achievement. If they can stop it, we don't really mind of keeping small doses of steroid. But we have to give them calcium, vitamin D, okay? And tell them about that side effect of the steroid always, like diabetes, hypertension. Okay, so low dose of prednisone, or sometimes you do like the osteoarthritis, you inject it in the joints. If it's only one joint, you cannot inject all the hand joints, of course. But if there is any one joint affected, yes. And make sure that you rule out cystic arthritis if it is inflamed and red and swollen. And now, where the money is in the DMARDs, disease-modifying agents. And this is the reason why I asked you at the beginning, have you taken this DMARDs in pharmacology? So DMARDs, they are very good, they are safe. They are not like paracetamol, they are, more toxic than this, but actually help the patient function, reduce the progression of the disease, and improve the quality of life. Do you need them or not?
Yes.
Of course, I'll take the risk. There is more risk, but it will help. So prevent disability, improve quality of life, okay? Interfere with the entire disease process. So it's trying to help you from that, getting worse and worse. Any questions so far? Yes? What are the demands? You need just to know them by names. And number one in rheumatology, especially rheumatoid arthritis, is needle fixate. Needle fixate. Second choices, you can see, they are azathioprine, gold, and others. Okay? You don't need really to remember all of them, but if I tell you which one drug of choice in DMARD is hydroxychloroquine will be second, number two. And I put it here for you just to remember. Right? Now, if the patient is not improving, or they have side effect, or they read about methotrexate, it causes liver damage, or teratogenicity, or something like that, we can use the anti-tumor necrosis factor alpha. Infliximab now, they really use it. They have a lot, actually. There is like probably 10 medications for rheumatoid arthritis. And one of them is the anti-TNF that we use subcutaneously. We call it adalimumab or Humira. Okay? We have other ones, the rituximab, Atacet, Amicandra, and Tocilizumab, and Tofacitinib also. We have more than this listed. Actually, it's listed here, Tofacitinib, the JAK inhibitor. It's an oral agent. Others usually subcutaneous or IV. This is an oral. Any questions about rheumatoid arthritis? You must threats of a drink for your patient. You will diagnose, you will manage, you will discuss the plans with the patient. Let me ask you, what are the pulmonary manifestations of rheumatoid arthritis? Pleural effusion. What else? Psoriatis. What else? Interstitial lung disease. Excellent. And BOOP. What is BOOP? BOOP. B-O-O-P. smiling. It's bronchiolitis obliterans organizing pneumonia, specific condition, okay? There is boom and there is cool, but this is one of them. Right. Let me ask you about methotrexate. Methotrexate. طيب, if anyone answered correct, I will promise to give her or give him a comment. I promise. طيب. But I'm sure that you're very smart and you know it, but sometimes it doesn't really come to your mind in this particular time. If I give a patient methotrexate, you want to try? Methotrexate. I give this patient methotrexate. What other medication you should give him? So all of you will next time bring a box of gums. I know it, that's it. So that's really folic acid. Why is that?
It inhibits the absorption.
By one, guys, we are not in Harajimi acid. One, raise the hand, I'll say, go ahead, we can hear. Would like to give it a try. Why we give folic acid with methotrexate? شفت بعدين ما حد لأن everyone is talking, I can't say it, no one will hear me. Go ahead.
Because methotrexate is an anti-metabolite, it interferes with the folic acid pathway, so they can't produce any purines. So we give a folic acid for the pathway to complete as what we need.
This is one, but the most important is actually.
And for anemia.
And even nausea and vomiting, even reduce the side effects. Remember that this is the third point. Right, let's switch gears now. Can you all stand up, please? All of you. Any disabilities, any joint pain, any head pain, back pain? Okay, back pain, no back pain because we are going through something.
Back pain, neck pain, bronze, like this.
Okay, thank you so much. Have a seat. Have a seat. No, guys, you can comment on your lecture, please. If you don't understand, raise your hand. Okay? If you understand, raise your hand. So now we covered osteo. I think it was very straightforward. There are only a lot of questions in this exam, but it's very straightforward. Rheumatoid, I can give you 100 questions about it. Because really, it's a systemic disease, it's complex disease, okay? Not easy to treat sometimes. Mortality, morbidity, that. Right, now we move to a different. So arthritis, we mentioned about gout, we mentioned about surgery, we mentioned about mono, but now we need to go and switch gears to another actually causes arthritis. Yes, please.
So, in rheumatoid arthritis, are the carpals affected or
What is that?
the carpal bones?
Carbon. It is joint. Yes, it can be affecting the wrist, of course. The wrist joints and the carbon. But usually it is the wrist itself and the MCP and proximus. The carbon usually it gets inflamed from the surrounding inflammation. But the carbon, rarely you get inflamed because you don't move them a lot. Okay? You don't move them. So let's switch gears now. I need to get my favorite place. Right. Now, when you stand up and you tell me that I do have back pain in the morning, this indicates what?
Bad posture.
Huh?
Bad posture.
Posture, okay, or maybe sleeping, not okay. Happens to many of you guys that you wake up in the morning and you have really back pain or discomfort, okay? Happens. Or you have taken like a heavy object yesterday and affecting your back, or spasm, or from cold, many things. Spondylarthritis is a condition that will affect the colon, spinal. Okay, good. Vertebral colon. Right, so we need to go through the definition of the neurology again, and I'm not going to example, but this is the thing that I want you to remember. That is. Can osteoarthritis cause back pain? Of course, because usually it's kind of you have rheumatoid, yes, but these are particular diseases that will fall mainly now exit. So they are family inflammatory conditions that will cause arthritis. And actually, which differentiate the spondyloarthropathy from the other forms and the distribution, okay? Distribution of the joint. The most common features is actually the rheumatoid factor will be absent in these conditions. And you have the HLA-B27 positive in such group, okay? Most actually clinical presentation will be lower back pain, and most of the patients will respond to non-steroidal. So if you give them painkiller, they do better. And they get morning stiffness, but when they walk around, the pain will ease and will be better. The main diseases are ankylosing spondylitis, okay? Is it more in males or females?
Males.
This one is more in males, okay? Psoriatic arthritis is actually common, and we see it a lot in combination with psoriasis, severe. Reactive arthritis, and we have what we call IBD associated, okay? Mainly with Crohn's and disease. Okay, so we know that it is more in men, and usually the age will be younger, at age 20, 27, like this, okay? And remember the HLA-B27. Do we need it for diagnosis?
Yes.
No, we don't. Even if it can happen in negative, most of them they will be positive, 90% will be positive. So it's a clinical diagnosis, number one, okay? Okay, so the features of the ankylosing spondylitis, features of the inflammatory back pain. Remember the inflammation, the joint can be either inflammatory or mechanical. When I asked you if you have back pain, how do you differentiate this is inflammatory or mechanical pain? Mechanical pain will get worse with activity. When the patient really well, when I wake up in the morning, I have a pain. But when I go around and climb step, I get worse. This is a mechanical. This is joint, either like prolapse or disc prolapse, or there's a vertebral issues. But if the pain gets less with activity, this is probably inflammatory, not mechanical. And one of the conditions is that ankylosing spondylitis. So it doesn't really improve with rest, not like the mechanical one. If they rest, they will be fine. Pain is independent of position. And again, there is gluteal pain, tenderness over the joint, reduced spinal mobility, extra spinal joints, and inflammatory enthesitis. What is this inflammatory enthesitis? What is it? So let's get confusing about it. What is enthesitis? What is it? It's inflammation of the tendon upon the insertion to the joint. Tendon inflammation. Okay. So the extra, again, remember rheumatoid. Ankylosing is again systemic disease that can be associated with and extra articular manifestations. Many. Can name it. Can spend like maybe 30 minutes just to name the conditions. So remember the pulmonary, prostatitis, aortic inflammation, eye, anterior uveitis, IgA nephropathy, and AV block. Okay? So there are many conditions can be associated with ankylosing spondylitis. What do you see? I don't explain. Is it a normal or abnormal? Okay, I hope that you know the normal to say this is abnormal.
Yes.
But what do you see? How do you describe it? Huh? Bamboo spine. Bamboo. Okay? Bamboo spine. This is acute or chronic? This is chronic. This patient has been ignored, okay, for years. So they get what you call it, bamboo spine. This is classical for a patient. So in the exam, for example, they tell you classical features and what, in which condition you see. This is ankylosing spondylitis. Okay? Again, for diagnosis, it's a clinical diagnosis. You can do the HLA, most of the time will be positive. And we do the inflammatory marker, could be related, like ESR, CRP. Okay, how you treat, by the way, ankylosing spondylitis? pain control, training, education, okay, prepare them for physiotherapy, and sometimes we give them anti-tumor necrosis factor alpha and biologics. You remember that anti-TNF like adalimumab, infliximab, rituximab can be used specifically for patients, okay? Because this is some sort of autoimmune disease. Psoriatic arthritis, so psoriasis usually, but it has a classical features. Usually they get what you call it, sausage-shaped fingers, usually in the hand, okay? And it is not that rare. We see a really good number of patients. And they have what we call decade arthritis, sausage-shaped fingers. It can mimic rheumatoid arthritis. If you remember the facial diagnosis of rheumatoid is psoriatic arthritis. Can mimic rheumatoid arthritis. But remember, rheumatoid factor will be negative. Arthritis motilians. So motilians will be inflammation and like telescoping sometimes of the bone inside the bone itself. Okay? So there are criteria. Okay, there are scores. I don't think that you will be in the exam will ask you what is this score, tell me about it. But remember, for psoriatic arthritis, there are criteria. Right. What is reactive arthritis?
After infection.
By the way, all of these spondyloarthritis, the treatment will be more or less the same. We need to again control the pain, treat the primary, and educate the patient. So reactive arthritis. What's-
Urethritis, arthritis, and conjunctivitis.
Exactly. So reactive to what? Infection. What infection? Two, either GI or genitourinary. Okay. So an autoimmune proceeds by GI or genitourinary infections. It triggers autoimmune. Many infections, we know they call it hit and run. Cause infection. The infection disappears, but it causes some sort of inflammation. Autoimmune triggers, okay? Inflammation. And this will go to the joint. Unfortunately, it goes to the joint, can go to anywhere, but this patient in particular went to the joint. So characteristic triad, conjunctivitis, as your colleague mentioned, urethritis and arthritis. And can happen with different organisms, as listed here in red. And it doesn't happen immediately, like the patient gets gastroenteritis or UTI now, it doesn't happen tomorrow. It takes some time, like a week or more, up to 4 weeks. Sacroiliitis, enthesitis, dactylitis, conjunctivitis, iritis, helenitis. This is some sort of like specific to the glans penis inflammation, keratoderma, oral ulcerations, and urogenital tract symptoms, dysuria, peritonitis can happen in those patients. Okay? So remember, this is a reactive inflammation affecting the joint, affecting the eye, affecting the urine.
Doctor, is it the same as Richter's syndrome?
No, that's different. Okay? Reactive is different from Reiter syndrome. Okay? So labs again, you can do the cultures, of course, you can test the urine, you can test the stool, can be positive or negative. Sometimes the patient already treated from this infection, okay? And get it. What other condition, by the way, in your mind, you get the infection, and later on you get autoimmune damage?
Pyogenic rheumatoid fever.
Rheumatic fever. Rheumatic fever, you get tonsillitis, pharyngitis, you take antibiotic or no, and later on you get damage. Like the same in reactive arthritis.
Doctor, what is the difference between Reiter's syndrome and
It
reactive?
has a specific criteria for Reiter syndrome. They get joint, but they have specific features. I didn't really cover it today, but I'm not going to ask about the exam. But this is a reactive. By the way, some books they combine it, Reiter and reactive arthritis. But for the purpose of this one, I am separating it. It's not part of it. So if you do a joint, if the patient has a joint inflammation, what you do? There's inflammation.
Aspiration.
You aspirate, but what you'll find in the joint? Of course, always, any joint there is inflammation, there will be WBC. Are they high or medium or low?
High.
High,
Medium.
usually septic. Very high would be septic.
2000 to
Elevated, yeah.
But elevated, but they're not normal. Okay, so be in the safe side. They're elevated, but they're not normal. So usually between 10,000 to 4,000. Usually septic arthritis, 100,000. But this one is inflammatory, not infectious. So there is no reorganism in the hand. Sorry, what IBD related? Okay, you can see with IBD, correct? Okay. And again, remember the IBD can affect many organs, okay? How to manage patient with spondyloarthritis?
Treat the
Well,
infection.
again, what we have mentioned before.
Also treat the infection, then treat symptoms.
If there is infection, of course, it has to be treated, okay? Now you need to control the pain.
Yeah, pain.
Okay, all patients must be provided with physical therapy and support. Smoking is always recommended. Screening for osteoporosis for some patients. Why? Because they are not going to mobilize very well. They are going to use steroid down the road. So screen for osteoporosis and give them calcium and vitamin D. We need to give patient painkillers, paracetamol, NSAIDs. Then what we call step up. Not improving, we go to the anti-TNF. Okay? And most of the time we use tuberculosis for ankylosing spondylarthritis. But still, others like, for example, psoriatic arthritis, we can use anti-TNF. We can use tofacitinib with jaclidine. And DMARD, remember the rheumatoid, we can borrow some of the medication from rheumatoid arthritis to give it to those patients. Okay? But again, physiotherapy is important. It's about, remember, spondyloarthropathy, when you come to the clinical practice, by itself is a lecture. Take the ankylosing spondylitis, take 30 minutes. Gouty, the gout is out, like psoriatic, take 15 minutes. But remember, now the conditions, the four of them, and remember the distribution, okay, remember the treatment, okay, and the clinical features, especially for extra articular manifestations, okay. And for example, reactive arthritis, what are the geniturinary, what are the organisms, and when this happens, like happen immediately or later on. طيب.
For psoriatic arthritis, it's
Septic?
no,
Psoriatic. Psoriasis arthritis.
Yes, it's asymmetrical, right?
It is most of them asymmetrical. Actually, most of them asymmetrical except rheumatoid arthritis. It is asymmetrical. But remember, psoriatic arthritis can affect, for example, joint in the wrist can affect the hand on the left side. But most of the time will be in the hand joint. Will be in the hand joint. Now, what do you know about gout? Teach me. Yes. Why?
consumption of meat.
Consumption of proteins and meat, okay?
Or purine-rich foods.
Huh?
Purine-rich foods, they have a problem with
There's
purine metabolism.
Exactly. So that affecting wood joint, yeah.
The metatarsal
What is
joint.
in Arabic? Can someone tell me in Arabic?
النقرس.
Naqras, okay? Naqras, and it's mainly in
Metatarsal.
wood joint, one joint.
First, the metatarsal.
First, metatarsal.
It's not
Excellent.
productive.
Okay, so always when asked about gout, remember, it's a disease related to this one, affecting this joint. But again, you have to go one further step to go more and more what is the cause of it. So what's the deposition of the what kind? Monosodium urate crystals. Monosodium urate crystals. So if you study the joint, you'll find the monosodium urate. Are they positive or negatively charged?
Negative vibe.
Negative. So they are strongly negative, okay, needle-shaped crystals in the joint, and usually related to the uric acid. Uric acid will be high. So what are the causes of uric acid to be high? So either increase the production or reduce the secretions. Increase the production like what?
Myeloproliferative disorder.
Exactly. Hematological disorders like tumor lysis, like polycythemias, leukemias, all this. So production. Or you are not secreting the uric acid. Renal, basically renal, or drug that will compete with uric acid. Okay? So let's proceed. Okay, we mentioned here actually, you see that business now with gout. It's increasing. Why? McDonald's or what? Okay, see the shares now, the global gout service is increasing. Okay? And actually everything more expensive. It's overproduction or under-secretion or competition for secretion by organic acids, like some drugs that will compete. Okay? Remember, one medication can lead to thiazide. Thiazide actually causes hyperuricemia, you know that? Okay? So an acute inflammatory arthritis that most commonly affecting a single joint. We agreed septic arthritis, gout, pseudo-gout, usually morning. Okay? Rapid onset of pain and inflammation. Usually the joints really swollen, red, tender, and rapid onset. Just overnight, or 2 days, 3 days maximum. Not like a week or 2 weeks. And sometimes having like asymptomatic period. The patient will do very well in between. Once the single attack happens, there is still chance of happening again. The patient is naturally educated how to avoid these attacks. Okay? The patient might have these attacks in the future. Serum uric acid is available in setting of acute attack because sometimes it drops down in the acute attack. So don't check the uric acid in the acute attack, we check it usually in the full protein. Usually the attack self-limited. The patient will take some sort of painkiller, rest, and it will improve. And can happen, but really as a polyarticular or oligoarticular, but usually it's single joint. We agree that monosodium urate is the culprit, is the crystal that will deposit in the joint space, causing the inflammation and immune response. This will result in the neutrophil infiltration of the joint as the hallmark of the gout. You can see here. What do you see? Can someone describe for me? I don't know if you can see it from distance. What do you see? Swelling. What else? Redness. If you touch it, painful. Excellent. And can the patient move it? Move the throat? Painful. Restriction. Exactly.
Do we see the swelling in every stage or in?
It's acute. It's acute. So the patient will not leave it. They will come to the hospital. Most of them, they will come and report it and has to be treated. So patients sometimes at home used to this one and they know how to manage it at home. They know this attacks and they take the painkiller and they don't. At the beginning, there is painful. But what would be your differential diagnosis if you see such cellulitis? So exactly, I like really this differential diagnosis. So picture of the skin, maybe it's not the joint. How do you differentiate between cellulitis and arthritis? No, I need a clinical, please. Don't go to labs. Movement, so you move the joint. Cellulitis, it's an infection or inflammation of the skin. If you move the joint, the patient will not really have that as discomfort or harm. Gout, the patient will not really like it. Okay? But very good differential, cellulitis. Psoriatic arthritis. I know this is a very small space, unlikely to get infected, but assume this is the knee joint. I should think about psoriatic arthritis. Okay. Remember the differential diagnosis I listed for you here. Can someone read them for me? Go ahead.
Septic arthritis, bony, trauma, septic embolus, SNSA, calcific periarthritis, and CPPD pseudogout.
So, you know the difference between gout and
One is
pseudogout?
calcium and
This is what? C, calcium.
phosphate, dehydrate.
This is a pseudogout. This is different from gout because the treatment is different. Okay? And I'm not covering the pseudogout today, but remember one thing. Pseudogout, there is a condition that precipitates this. Like patient in the hospital, for example, they are losing diuretics, they have, for example, hemochromatosis or Wilson disease or They have osteoarthritis at the beginning. It can get to gout, but gout is totally different. Okay, you agree with me?
Yes.
This is
Gout.
strongly negative or weakly positive.
Negative.
Strongly negative. Weakly positive is that pseudo. Okay. So again, if you aspirate the joint, is the inflammatory marker will be normal in the joint, will be low or will be very high?
Very high.
No, will be in the middle. Okay, very high, which one?
Psoriatic arthritis.
Septic pus, more than 100,000. But this one, say
10
between
to 40.
10,000 to 50,000 like this. You think this is very high? It's nothing. So how you treat the gout? So try to prevent. Prevention better than cure. Try to prevent the attacks. If this is happening again and again, try to prevent it. If the patient has a kidney problem, try to solve it. If the patient has overproduction of leukemias, of course, has to be treated. The patient is consuming a lot of red meat, have to cut down. Okay, with repair non-steroidal. So you have two cases. You have to treat the acute phase and you have to prevent this episode from happening again in the future. So in the acute phase, you have to just treat. Like you have the fire, you have to control it. Then try to prevent it from happening again. Well, this is not safe. You cannot put like the man with this close to the scales or no. Prevention. But now I have to forget about we need to control. The patient really screams for pain. So number one, I would like to rule out, as you mentioned, spondylitis or cystic arthritis. There is a need for joint aspiration, just to make sure that I'm on the safe side. Not to give steroid, not to give something, and the patient is having infection. So control the pain, give steroid, sometimes intra-articular steroid, sometimes used for like short period. Oral colchicine. Oral colchicine. Okay, and what's the side effect of oral colchicine? GI, upset, diarrhea maybe. They said the patient will run before they walk. Okay? They run to the bathroom before they start to walk. Because they, and I said, give it every 1 or 2 hours, the colchicine, it's actually, it is a herbal from a flower. They can take it until the pain is controlled, then please slow down. Okay? Clear? And how to prevent is you give the xanthine oxidase inhibitor, which is the allopurinol. Allopurinol to prevent actually the infection. So, usually give 10 milligram, but remember it's clear by the kidney, you have to be very careful. And always look at drug-drug interaction. The patient is using like azathioprin or using other medications, review before you give the serum. So it lowers the serum uric acid, but remember, uric acid is not accurate in the acute attack. So you measure it in the clinic when the patient comes to you, they're happy, check it. Any questions about gout, pseudo-gout? Pseudo-gout, I didn't cover it, but treatment more or less the same. We rarely use colchicine or only painkiller. And it is a primary disease for pseudo-gout. Any question?
Doctor,
Yes, go ahead.
why not use rasboric acid instead of allopurinol?
You can use it. But the most likely the drug that we're using is the intravenous. So monoarthritis, keep in mind gout, pseudo-gout, septic, osteo sometimes. It's a medical emergency sometimes because you need to rule out infection. Because if you keep the infection and give the patient steroid, this will cause more harm. You agree? So think about always outside the box. If even the patient has gout, comes to you with a pain, think about it. Osteomyelitis, this is different. Now forget about the joint space. Now we're talking about the bone itself. Okay? Bone. Okay. With infection. Okay? Remember there's an infection going on. And more in men, as I told you, like ankylosing spondylitis, there are conditions that are more common in men and conditions that are more common in women. And increase with age. Can someone tell me a story. How does the patient present osteomyelitis?
Bone pain.
Trauma, exactly. So the patient has a fracture or something, inoculation of the organism, yes. The bones actually are protected, they are nice. How it come the organism will go
Post-surgery.
enter that bone?
Zibidus ulcers.
Hematology.
Post-surgery.
Zibidus ulcers. Zibidus ulcers.
Ulcers?
Hematological.
Okay, hematological. Okay.
IV drug
If the patient is bed-bound and they are having like a decubitus ulcer, can penetrate to the joint and the head, yes. Okay. What else?
Post-surgery.
Post-surgery, sometimes infection, post-surgery diabetics. Patient was diabetes, they get the blood flow to the bone will be less and the immune system is also weak. So if there is any organism go there, or hematological, or by trauma, or by direct, it will cause inflammation. And you don't control it, and you don't recognize it early, it will cause osteomyelitis. So again, I agree totally with you that trauma from accidents, IV drug use, diabetics, they have peripheral vascular disease and they are immunosuppressed, keep in mind, they get osteomyelitis. Sicklers, salmonella, exactly, salmonella and sicklers. But keep in mind, what's the most common organism for?
Staph.
But salmonella, they do have more, actually, number of salmonella. And prosthesis, like if the patient has joint replacement, or sometimes they get like metal part after accidents, can lead to inflammation. I think you have to keep in mind the organism is very important for exam, staph aureus. Okay? Because you will treat the patient empirically at the beginning. Okay? So treat, you will not wait for how do you diagnose osteomyelitis? How do you diagnose it? Diagnosis? Okay, aspiration or culture, okay. MRI imaging, we need to look at the imaging. Again, before MRI, do they do it at night? No. X-ray can do it, but it's a medical emergency. So you give the patient antimicrobial, then you bring the radiologist, you bring the doctor to take the biopsy. I agree with you that salmonella is really quite common in sectors, but keep in mind that Pseudomonas, the patient has recurrent attacks of UTI, keep the E. coli in mind. And bites like from any animals or something. So the spread, the most common is the from the blood. Okay? Trauma, we mentioned about it. We mentioned about soft tissue infections. Septic arthritis. The patient has septic arthritis or the decubitus ulcer can split there. Okay, this is very important to keep in mind how the infection starts in the body. Doesn't blow up like overnight. It takes some time. Usually it is acute, then ignored to be chronic. What are the causes of chronic osteomyelitis?
Infection.
Immunodeficiency people.
No, this is actually acute, but chronic
Immunodeficiency.
immune deficit. But there is a condition which is
Diabetes.
no infectious. Infectious condition in Saudi Arabia that can lead sometimes to osteomyelitis. TB, excellent, and brucellosis. Brucellosis. Do you know what is brucellosis?
Yeah.
Can lead to osteomyelitis, and TB can lead to chronic osteomyelitis. So these two conditions, particularly patient will have insidious onset, will be ignored for some time, and they will present as chronic osteomyelitis. But now we are talking about the acute. When the staph comes, everyone will disappear. Very strong organisms that will cause acute osteomyelitis. So it will cause acute inflammation, okay? And this will lead to subperiosteal skin abscess. See this one? This will lead to a sinus and elevation of the periosteum here. See this one? Septic thrombosis. This will cause necrosis. Again, after all this compression, the blood supply will be even less and less, and the pus will grow up. Okay? Will grow up, and this will invade the bone marrow later on. So go out and inside. And this will lead to what's called osteomyelitis, severe osteomyelitis. So the patient will present usually with again signs of inflammation, pain, swelling sometimes, fever, okay? And you ask the patient about what happened to you, whether they have, for example, manipulations or have trauma, or like the patient is diabetic, they have, for example, diabetic foot. You know, diabetic foot, sometimes they get like a gangrenous part, this part, that will go from skin to the bone and spread, and sometimes they need amputation. Just ignore them, not recognize them. So the famous swelling tenderness, you agree, and sometimes you see a sinus. You see there is like a trap, like a pin hole, and from the skin, you see there is pus, and if you squeeze, there's pus coming. Sometimes you see fragments of bone coming, like a chop. Okay. If you do the labs, again, the patient might have inflammatory markers. ESR will be high, CRP will be high, WBCs will be high. Do you agree with me? Or they will be elevated, inflammatory markers. Are they diagnostic? If you do blood culture, can be positive for staph. Okay? Can be positive for salmonella. Again, the patient has sickle cell, keep in mind salmonella. X-ray will be normal at the beginning, but remember the periosteum will be still not affected, but later on will cause the damage. Then periosteum elevation, lytic actually areas, lytic not direct, lytic area, which is eaten or fragmented part, and blood culture again, important always to look for blood culture because the bone marrow, or sorry, the bone biopsy, it will take time, so we don't do it overnight. Some need to be specialists, bring us sterile needle and take from the bone itself. Because you need this to be cultured. But if there are blood from two different sites showing staph, and Dr. Sahabani tell you whether the lecture is the most common, it is the most common. And look at the sensitivity of staph aureus to that, lymph So again, gold standard diagnosis is gold standard. Bone biopsy. What are the complications? What can happen? If the patient didn't come to you.
Sepsis.
Sepsis, what else?
Osteoporosis.
Necrosis, excellent. What else?
One more
Ali, in front of you.
Septic arthritis.
Okay, can I feel the joint? Respect to the joint again. Okay. Loss of function. Fractures, okay, amyloidosis, any chronic inflammation, if you ignore it, that might lead to secondary amyloidosis. And sarcoma is there, so it can develop like some sort of sarcomas. Now, treatment. What's the most common organism? Staph. Now, what are the antimicrobials that will cover Staphylococcus aureus? Or Cefazolin. Okay, what else? Vancomycin for, okay. For methicillin resistance, MRSA, yes. Vanco, very good. So now we need to give the patient oral or IV? IV. Why? Fast, you are sure that it's going to the system, hematological, go to the bone. And remember, sometimes the patient oral, they get nausea, they skip the dose. So you will see here, empirical. Because usually the patient comes to the emergency room, I'm not ready for bone biopsy. Treat. It will not really affect the culture if you do the bone biopsy after the day or two. Specific, and usually the IV for 6 weeks. Not a week, not a day. So intravenous in the hospital. Sometimes they can go to the like day center, they can give it, okay? But it has to be intravenous. And if it's a chronic, you can extend it up to months. Okay? The bone is difficult to treat. Like endocarditis, you need weeks. It's not like a UTI, you give it for 5 days or 7 days, or pneumonia 10 days. This is an infection that it is difficult to be treated. Again, without penicillin or cefazolin, I like these two, but again, keep an eye on the kidney function, on allergic. If the patient has MRSA, Visa, Persa, this is the vancomycin intermediate staph aureus or vancomycin resistant You can use the needles. This is again, you look at the blood culture and the bone biopsy culture and sensitivity. The microbiologist will tell you. Now for TB, they go to what's called Bot's disease in the vertebrae, okay? And can affect any joint. How you treat that, actually, it's a chronic treatment of Bot's disease. So the patient will have a history of fever, weight loss, a chronic pain, differential diagnosis, either brucellosis or tuberculosis. We do all specific tests for TB, including the cultures, which will grow the organism. And the treatment also going to be very chronic to cure that disease, the Bot's disease. Again, you have to drain. If there is an abscess, you have to drain it. You debride, management of the dead space, and all the soft tissue has to be covered and supplied. Okay, so we covered today osteoarthritis. I think you remember the presentation of the lady with her hand. Then rheumatoid with polyarticular. Then we went to the spondylarthritis, the 4 conditions that affect mainly the back and the lower back, sacroiliitis and spondylarthritis. Then we covered gout plus psoriasis. And we covered the osteomyelitis, which is very different from all these joints. Okay? I have actually looked at the objectives of your lectures. I think for your level, they have to be specific. And for me, I don't need to present for you, for example, osteoarthritis. Should be kept in orthopedic maybe rotations. For you, eccentric arthritis is important, but I didn't cover it. But keep in mind, it is a medical emergency, comes with pain, plus, and has to be treated immediately, okay, and you aspirate and you sometimes irrigate the joint. For me, spondylarthritis is complex, need by itself really time for a lecture, like for 1 hour at least, because I need to ask questions about it. Now it's the time for your questions. So, was it easy to understand? Yes. Or you think it is really complex? Or you think it's to the point?
To the point.
I think it's to the point. Sometimes, if you bring a specialist, I'm really serious. If you bring like a GI to tell you about Crohn's disease, if he doesn't know your level, it will be too advanced for you, and you will leave this room confused. But if I bring, for example, an internist talking about Crohn's disease, he will prepare it for his demand. It will be easy for you to understand that. And this is what I have done. For me, as a really internist, this is what I need to know. I'm not giving you a fellow level of rheumatology or consultant. This is for you. I think you know the difference, the approach, clinical manifestations, the labs, investigations, x-rays, and how to do it. This is for you, and I hope it was really clear. I'm going to keep my PDF format here. Can someone just educate me about reactive arthritis versus? Prepare for her, reactive, yes, versus Reiter disease. I want her to read for us.
From where?
Read from where?
Is this internet here, by the way?
Formally no, but from here.
Okay, what's your name? Sama? 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 Sama, she will tell us now. Her colleagues are trying to help her, because there was a question from your colleagues. What's the difference between reactive arthritis and Reiter syndrome? Syndrome, remember, is constellation of syndrome. And we said there is a way that you can differentiate. There is something called Google search. Go ahead. Can you just,
So it says reactive arthritis, commonly known
same condition.
Yeah.
Why they are saying it's sometimes different?
Because of the
Why we didn't put it right there? Why not remove from the,
for the diagnostic
yes, yes,
Because of the trigger.
trigger.
One occurs in many joints at the same time, and one occurs in one joint.
No, my question, is it the same like Sana mentioned?
No, it's not.
Same condition?
It is.
It is.
Your colleague here, there is no argument between males and females. I like that argument.
Dr. Oban told us that they're not the same.
Okay,
Also
let's argue for 2 minutes, no problem. No, Sama said that arthritis is reactive. And your colleague here start to challenge us, says, well, I'm not the same. What's your argument?
I'm not sure, but Dr. Oban said that they're not the same. There's a lot of research to say that.
Now we go on. Go ahead. Yes. Raise your voice, please.
Arthritis syndrome is associated with other signs like urethritis, conjunctivitis. Reactive arthritis is just affecting the joints.
So reactive arthritis is part of arthritis.
Yeah.
Can you say that? Can I agree with that? What do you think?
the arthritis portion of arthritis syndrome is reactive arthritis.
So part of arthritis is reactive arthritis.
So you mean that psoriasis is arthritis, arthritis, conjunctivitis, and
Yes, but is it arthritis? Is it reactive? This is my question. What do you think? Same? So let's agree on this. We'll ask you in the exam. This question? Well, let's go to the next side. What do you think? Guys, tell us. What did you read? Huh? Yes, that Ambus is confusing. Step up and step down. They ask me always from where we read step up. I said no, read step down.
Yes, exactly. It says the writer has other symptoms like he said.
Okay. What about reactive arthritis?
But
So, agree. Okay, guys. Your colleague think that reactive arthritis is part of arthritis. It's the joint itself. But for me, actually, I find it arthritis has been removed. No, they just go to the reactive arthritis.
I think يعني
We will, no, I have a lecture with you, I think next week. I will be elaborating this, that's a really good question, good challenge for me sometimes. I go and review, and we'll come up with the one slide. Thank you so much.